All right. Good morning, everyone, or afternoon, depending on where you are. Welcome to our echo session today. Again, deviating a little bit from our work that we normally do with Chagas disease, we are focusing on a new hot topic called the New World Screwworm. So obviously you're here because you've heard about this, so we welcome you. I know we still have quite a few people logging on. So I'll probably give it about one more minute, but I wanted to thank you all for also changing course with us on a new topic and then also getting a new webinar link. We found out that this session was so popular, it superseded our 300 limit. So we had to change the link for a bigger audience. So we're going to give everybody about one more minute to sort of get logging on. I see we have about 300 participants so far. So if you're joining us today, thank you so much for being here. Give it about one more minute. Okay. That wasn't quite a minute, but I think we have a few minutes that we're going to cover opening up the session, and we have a lot to cover today. So I'm going to go ahead and get us started. We have a couple of just small housekeeping items that we want to cover. I'm going to go ahead, next slide. So this is an accredited session, so you will be able to apply for continuing medical education credits. It's 1.5 credit for this session. It is free, but in order to do that, you have to be sure to fill out the evaluation that we will provide a link for in the chat, and then also at the end, we'll have a slide with the QR code so that you can grab that, make sure you take it. And then about 3 weeks, we should be able to send you your certificate by email. Next slide. So our agenda today is we're just going to do a quick welcome. This is our introductions and announcements right now. We do have our guest presenter, Dr. Rebecca Chansey. She's going to be giving our case presentation and our didactic. We do have a Q&A that is set up. You can see on your screen a Q&A button. And with that, you should be able to put your questions directly into the Q&A. And we have also a couple of representatives from the CDC, Dr. Sue Montgomery and Dr. Fox as well here with us, who they are both able to help facilitate answering some of those questions. And then the questions that we would like for Dr. Chansey to ask, we will hold those until the end. And then we'll have some closing remarks at the end. So plenty of time for Q&A at the end as well. Next slide. So with that, I'm going to go ahead and do our introductions. We are really lucky to have Dr. Rebecca Chansey here with us. She's a medical officer at CDC, where she focuses on parasitic diseases and emerging zoonotic threats. She's also been a co-author of the pediatric review article, Congenital Chagas Disease, that was published back in 2023. So that's also her link with us to the Chagas world. She's also had over 45 journal articles and book chapters on a numerous amount of parasitic diseases, so an absolute expert here with us today. As a pediatrician, she also has a strong interest in the clinical management and public health epidemiology of parasitic infections, especially in children. She has been an invited speaker at many national and international conferences and is quite passionate about educating others on parasitic diseases. And she is currently recognized for her work in raising awareness about the resurgence of New World screwworm and its risks to human and animal health. So we're very lucky to have her with us today to give us more information about this disease. Next slide. And just to introduce myself, for those of you who have not met me before with our Chagas Echoes, I'm Dr. Paula Stigler-Granados. I'm an associate professor at San Diego State University, where I lead our environmental health division. I have also had about 10 years of expertise working on Chagas disease with our longstanding CDC cooperative agreement that helps to fund our echo sessions. And we're focused on educating and community engagement for all of these diseases that we're talking about. But again, my focus has been on Chagas disease. I work with organizations like the Department of Defense on Chagas disease and military populations, and I've been leading these echo sessions for about 8 years now. My broader research is on social determinants of health and environmental issues in health along the U.S.-Mexico border. All right, next slide. So again, as I mentioned, there is CME available for these. If you would like, you will fill out the evaluation at the end, and we'll show the slide again at the very end, and we'll also put it in the chat. And with that, we are going to turn it over to our presenter, but I also just wanted to mention again that we do have a Q&A feature at the bottom of your screen. If you do have a question that comes up during and you want to put that in there, we do have representatives that are able to help facilitate answering some of those questions, so please feel free to do so. We also have closed captions if you need to do that and to turn that on at the bottom. And I think with that, also, if you're having any technical issues or any questions that come up that are not specific to the topic, you can also put those in the chat, and all of the co-hosts and the panelists can see that chat. We'd be happy to try to answer. I'll be watching that to answer any of those questions as well. All right, and with that, I'd like to turn it over to our presenter to go ahead and get us started.
Thank you very much, Paula. Let me just share my screen. Okay, can you see the slide presentation?
Yes, we can. It looks great.
Okay, perfect. Yes, thank you so much for having me today. As she said, I'm Dr. Rebecca Chansey, one of the medical officers in the parasitic diseases and malaria at the Center for Disease Control and Prevention, and I'm excited to talk to you today about the resurgence of New World screwworm in the Americas. I have no conflict of interest to disclose, and before we start the presentation, I just want to make you aware that some of the pictures and images you may find disturbing, especially if you happen to be eating lunch at the moment. So some of the objectives of this talk, we plan to explain the life cycle of New World screwworm and why the maggots are a threat to animal and human health. We want to describe the current outbreak of New World screwworm that's currently happening in Central America and Mexico, and summarize how to identify and treat New World screwworm infestations that you might see in your patients. We also want to discuss the importance of reporting human and animal infestations in order to help prevent further spread of this pest. So we'll start off with a poll question to see how much you already know about New World screwworm. So I'm glad to see it looks like some of the people have watched the Coca call that we did last fall. That's definitely available online, and you're welcome to watch that as well. And then I'm glad to see that there's a wide variety of people who are joining us today. People who don't know anything about New World screwworm, and some who've seen some of it in the news, and some who have a little bit of knowledge. So thank you all for coming. So, why do healthcare providers need to know about New World screwworm? As I mentioned, there is an ongoing outbreak of New World screwworm in Mexico and Central America that poses a threat of reintroduction into the United States, especially in communities along the southern border. The New World screwworm myiasis can be a very severe illness in patients and may also contribute to a patient's death. Humans, as they move, can transport New World screwworm into new areas where the flies are not currently present. And we have had cases of New World screwworm myiasis in travelers who are returning from areas and they bring the New World screwworm into the United States and Canada. So New World screwworm, the scientific name is Cochleamia hominivorax. It's a fly, and the fly's parasitic larva can cause a form of myiasis. The female flies lay eggs directly on existing wounds or exposed mucous membranes. The larvae or the maggots of New World screwworm are obligate parasites that consume living healthy tissues. It's primarily a pest of livestock, but it can also infest humans. And companion animals and wildlife can also be infested. Hundreds of eggs are deposited within minutes by the female fly, and these eggs turn into larvae that then lead to extensive tissue destruction, debilitation, and risk of death. The New World screwworm adult flies are about the size of a common housefly or slightly larger. The fly has orange eyes, a metallic blue or green body, and 3 darker longitudinal stripes down its back. They can fly up to 2 to 15 miles depending on habitat and food sources. The male flies typically feed on flower nectar, and the female flies feed on living tissue from wounds because they need protein to make eggs. The female flies mate once in their lifetime, but the males can mate more than once. The female flies lay around 300 to 400 eggs on a host adjacent to an existing wound, and the eggs can hatch within 24 hours. The screwworm larvae burrow into healthy living tissue for up to 7 days. And then after maturation in the host, the larvae drop out and become pupate in the environment. Adult flies emerge from the pupae 7 to 54 days later, ready to start the cycle all over again. And you can see here on the slide, this is a picture of the pupae. The adult flies, after they emerge, the males are ready to mate immediately, and the adult females are ready to mate approximately 3 days later. And all of this cycle depends on the ambient temperature and humidity in the environment. This is a picture of the life cycle on the left and a picture of a wound that demonstrates all of the stages of the life cycle on the right. You can see multiple egg masses in white here in the picture, as well as several female flies and multiple larvae or maggots that are crawling around. Once an infestation is present, additional flies could also be attracted to the wound to lay eggs, and so you might see different stages of larval maturation as well. The term screwworm refers to the screw-like shape of the larva and the way the larvae burrow into the flesh. Morphologic examination of the larva is vital to correct identification of New World screwworm. The larvae are usually between 6 to 17 millimeters long and taper anteriorly and truncate posteriorly. They have encirculating bands of 1, 2, or 3 pointed spines on each body segment, as seen in this close-up picture. The best features to distinguish New World screwworm larvae from other similar larvae that cause facultative myiasis are the tracheal trunks. The tracheal trunks lead from the posterior spiracles in the back and are pigmented dark brown to black. The pigmented portion extends anteriorly across at least 2 full body segments. And you can see the picture in the lower right in this slide has a good view of the peritreme as well that we'll talk about next. The peritreme of the posterior spiracle is another unique feature of the New World screwworm larva. The picture on the left, the P represents the peritreme and the B represents the button. You can see that the button is quite faint or indistinct, and the peritreme is incomplete and does not close the area of the button. So now we're going to discuss the history of New World screwworm in the US, including its eradication and some of the reintroductions. But first, let's ask poll question number 2.
Rebecca, this is Paula. Just for the future questions, would you mind reading them out loud, just for the people that are using closed captioning as
Oh,
well?
sure. Yes, thank you.
Mhm.
So the question was, when was New World screwworm previously present in the US? And the answer is all of the above are correct. So I was glad to see a distribution of responses, and we will go through the history now. So New World screwworm was present in the US prior to 1966, initially only in the Southwest, and then it was introduced into the Southeast in 1933. Because of the significant impact of New World screwworm infestations, USDA developed an eradication strategy based on the release of sterile male flies. As we mentioned before, the female New World screwworm fly only mates once, and the sterile male fly can mate with wild type females multiple times. So the female fly, after it's mated with with a sterile male fly, will lay hundreds of unfertilized eggs that never hatch into the parasitic larva. At the time, outbreaks were managed using the sterile insect technique, as well as intense monitoring with prompt isolation and treatment of infested animals. New World screwworm was successfully eradicated from the US using this sterile insect technique in 1966. There were occasional incursions into the southern US that still occurred while the flies were being eradicated in Mexico. USDA established a New World screwworm control program, and over the next 40 years, the control program continued to push the fly down through Mexico and Central America, ultimately achieving eradication through Panama by 2006. You can see on this map on the slide all of the different decades where the program was active in each of the regions using the sterile technique to push the flies down. New World screwworm remains endemic in South America, as well as Cuba, Haiti, and the Dominican Republic. The USDA APHIS and Panama's Ministry of Agriculture Development maintain the only New World screwworm fly sterilization facility in North America currently. And this is a picture of the New World screwworm fly sterilization facility in Panama. COPEG, which in Spanish is the Comisión Panamá Estados Unidos para la Erradicación y Prevención del Gusano Barrenador del Ganado, or the Panama United States Commission for the Eradication and Prevention of the Cattle Borer Worm. It's much easier to say COPEG. It is the organization and the production plant that makes the sterile flies in Panama. The fly production plant was inaugurated in 2006, and this plant sterilizes New World screwworm flies using the gamma rays and releases the flies into the region in Panama to maintain the biological barrier at the Darien Gap. Normally, in normal times, 20 million flies are produced for routine maintenance of this barrier. But currently, during this outbreak, production is at or above capacity with over 100 million flies produced per week. The flies are currently produced in Panama, but brought all the way up to northern Mexico, to the northern part of the outbreak, which is in southern Mexico, and that's where the flies are being distributed currently. In 2016, there was a local outbreak of New World screwworm in key deer in the Florida Keys. The response that followed was a large multi-agency response led by USDA. USDA released over 188 million sterile flies and applied over 15,000 individual doses of medication to at-risk deer in the region. New World screwworm was eventually re-eradicated in the Florida Keys in 2017. Unfortunately, the source of the outbreak was never identified, and the total cost of the USDA response was around $3.2 million. So now let's talk about the current outbreak in Central America. The release of sterile flies, as I mentioned, maintained the biological barrier at the Darien Gap in Panama, holding New World screwworm back from progressing into Central America until around 2022. In August of 2022, New World screwworm was detected in animals in Panama. And then in 2023, the New World screwworm detections in Panama increased to more than 6,500 cases in 1 year. And since that time in 2023, New World screwworm has progressively moved northward and has now reemerged in every single country in Central America and Mexico, and has affected both animals and humans in every single country. This is a representative timeline of the New World screwworm outbreak in Central America and Mexico, indicating when animal and human cases first appeared in each country. The important thing to take away is that you can see in every country, animals were the first to be infested, and then human cases appeared sometime after animal cases. And as I said, all countries in Central America and Mexico are now reporting human cases, and many of those first human cases have been since the beginning of 2025. This map from USDA represents the northward spread of the New World screwworm fly from southern Panama into southern Mexico. As I mentioned previously, the New World screwworm fly breached the barrier established by USDA at the Darien Gap in 2022. And you can see the black line at the lower edge of the picture of the map is the Darien Gap. The flies have progressively moved northward over the last 2.5 years and are now present in southern Mexico. A few months ago, New World screwworm crossed the next barrier that USDA was hoping to hold, which was at the Isthmus of Tehuantepec, labeled here in the middle of the map. The spread of flies northward into Mexico beyond the Isthmus of Tehuantepec is concerning for potential incursion into the United States. There are challenges with surveillance in many of these countries and potentially underreporting of cases. At the moment, we are aware of about 760 human cases in the region, which includes 6 deaths, and over 116,000 animal cases in the region, which includes wildlife, livestock, and companion animals. And we'll talk more about the human cases a little bit later in the presentation. The progressive northward movement of New World screwworm flies in Central America and Mexico are likely the result of several factors. The varied topography makes surveillance difficult, and reaching cases to treat them is difficult. Rural communities live in hard to reach areas that can make outreach efforts difficult. Communication across language barriers can also be challenging. There's potentially inadequate wound care for animals that predisposes them to infestations. There's unmonitored migration of infested wild animals across the region, and then potentially importation of companion animals from impacted countries to non-impacted areas. And then one of the primary things that we've seen is illegal movement of cattle through irregular and unmonitored checkpoints that has allowed New World screwworm to move outside of the sterile fly release areas. International partners, along with USDA, are working towards control efforts in Central America and Mexico. These efforts include aerial or ground release of sterile male flies in southern Mexico at the northernmost point of the outbreak. There are animal movement controls that include checkpoints for livestock transport and inspection of animals at slaughter. There's activities in the field that include farm visits and increasing surveillance to report animal and human cases. And there's ongoing work to educate communities and livestock producers, human healthcare providers, and migrant health workers, as well as veterinarians, animal health workers, and wildlife management officials. In the US, USDA has initiated a domestic readiness and response activity that includes increased monitoring at the Texas-Mexico border with fly traps to detect New World screwworm flies, as well as a specialized USDA mounted patrol officer called a tick rider, who can help identify any animals along the border with a possible New World screwworm infestation, as well as border crossing inspections. If New World screwworm does reach the US, USDA's strategy for eradication will include use of the sterile fly technique, development and enforcement of animal movement controls, and increasing passive and active surveillance, outreach, and education in impacted areas. You may have heard a few months ago during the summer that as a result of the northernmost active case in Mexico at the time, which is currently classified as an inactive case, it was identified 370 miles from the southern U.S. border in southern Texas. USDA closed the southern border ports to livestock trade, and they released a press release about this decision on July 9th, which you can find on this webpage. While efforts are ongoing in the past were ongoing to eradicate the fly from Mexico, an outbreak of New World screwworm occurred in Texas in 1976, And at that time, it cost the Texas economy millions of dollars. Recently, USDA made an estimate on the potential economic impact of New World screwworm in 2024 based on the scale of that 1976 outbreak in the past. And they estimated that the Texas economy could lose $1.8 billion in 2024 dollars if there was a New World screwworm incursion the size of the Texas outbreak in 1976. So future New World screwworm eradication effort plans, the USDA estimates that a coordinated response to push New World screwworm back down to Panama will take multiple years. And so while this is ongoing, CDC will continue to collaborate with USDA and other One Health partners from public health, animal health, wildlife, and environment. But ideally, we need rapid identification and correct disposal of larvae to aid eradication efforts and avoid further spread. And so that's why we're trying to educate all of you today. All right, so poll question number 3. Which countries currently experiencing an outbreak of New World screwworm have reported human infestations?
Rebecca, can you also read the potential
Yes,
responses?
the answer choices are Belize, Guatemala, Honduras, Panama, or all of the above. Okay, great. So the answer is all of the above. All of the countries in Central America and including Mexico have reported human infestations. So now let's discuss some of the clinical considerations for New World screwworm myiasis in humans. New World screwworm myiasis presents with very painful wounds. The patients describe a feeling of sensation of movement where the larvae are located, and there's often a very distinct, foul-smelling, bloody discharge. This isn't an infestation that patients can ignore, and so I anticipate that if an infestation is present, they will seek medical attention. There's often extensive tissue destruction that continues to worsen the larger the larvae remain in the wound, which can remember is up to 7 days. Larvae can be seen moving in and out of the wounds oftentimes, and you can see in this picture, there's New World screwworm larvae filling an ulcer in a patient who has lymphoma. Oftentimes, New World screwworm infestations can lead to secondary bacterial infections, which can then lead to sepsis and potentially even death. New World screwworm can cause infestations in any wound, even a wound as small as a tick bite. And any area of the body can be infested, including the scalp. Any mucous membrane or body opening can be infested, including the ears, eyes, nose, mouth, even the genitals or the rectum. People who are at higher risk of New World screwworm infestation include those who have open wounds, especially if the wound is already foul-smelling or ulcerated or infected with bacteria. That tends to attract the flies even more readily. Conditions that compromise the skin, such as eczema, psoriasis, or hyperkeratosis, are a risk factor. Compromised immune systems or diabetes, and especially a decreased ability to protect themselves from flies and insect bites, poor personal hygiene, or someone who's elderly or incapacitated. People who are outside working around infested livestock or other animals are also at a higher risk of New World screwworm infestation. People who sleep outside, especially during the day when the fly is active, and people who engage in outdoor activities in areas where the flies are circulating. People can protect themselves from New World screwworm flies by keeping skin wounds clean and covered, including those on the scalp that are often forgotten to be covered. Ideally, you want to limit exposure of the skin to flies by wearing loose-fitting long-sleeve shirts, long pants, socks, and a hat. You can use effective insect repellent, ideally containing DEET, to prevent tick or insect bites. And then treating clothing and gear with 0.5% permethrin can also hopefully decrease any insect bites. And sleeping indoors or in rooms with screens decreases your exposure to the flies. People with a suspected New World screwworm infestation should seek healthcare provider immediately. And once they do come to medical attention, all larvae must be removed, and this may require surgical extraction. Removal and proper disposal of the larva by a healthcare provider will both help prevent the spread of New World screwworm in a new area and obviously also treat the patient. The treatment of a New World screwworm infested wound, as I said, the priority for treatment is removal of all larvae. Once all of the larvae are removed, you can debride the necrotic tissue and allow the wound to heal and by providing appropriate wound care. Allowing the wound to heal will also prevent reinfestation. This is a very painful wound, and the extraction process is also pretty painful, and so providing pain management as needed is important for the patient. Antibiotics, as I mentioned, may also be needed to treat any potential secondary bacterial infection. This picture shows the collection of larvae that were removed from one of the travel-associated patients that we'll mention in a moment. And if you click on the link here, it goes to the media interview that the patient did after he was infested. There are no clinical studies of ivermectin use for New World screwworm in humans. There have been case reports published in the literature of off-label ivermectin use as a supplement to attempted removal of the larva. So because New World screwworm infestation in a patient should be considered an urgent public health event, we request that if you have a patient with New World screwworm or suspected New World screwworm, immediately contact your state public health department, your state public health veterinarian, or your state epidemiologist. You can find the state epidemiologist on call at this link here from the Council of State and Territorial Epidemiologists. CDC is also available 24/7. During the daytime hours, we're available at the email parasites@cdc.gov or the phone number 404-718-4745. And then because this is considered an urgent public health event, we are on call 24/7 and can be reached through the Emergency Operations Center at 770-488-7100. And we have telediagnostic services available, and you can reach the lab at dpdx@cdc.gov. So now let's talk about a differential diagnosis for myiasis in humans. There are other flies that cause myiasis in patients in the US. Obligatory myiasis, which is what New World screwworm is, the larva must infest a living animal. And we do have some other flies in the US that are endemic that cause obligatory myiasis. Many of them are veterinary or wildlife pests, but occasionally may infest humans. The sheephead fly that causes ophthalmomyiasis is one of those examples. But for example, the larva in this fly cannot mature and go through their life cycle in a human, only in a sheep. Many of these flies are specific to their host, and the humans are not the host that they prefer. The facultative myiasis, or also called opportunistic myiasis, the larvae of these flies consume decaying organic material, but can infest a living animal if there's an unclean or a necrotic wound present. And this is the myiasis that's much more common in the US and that you may have seen already in some of your patients. It's often associated with people who are bedridden or unable to prevent or protect or clean their sores or wounds. And the common housefly that you can see in the picture here is one example of a fly that potentially could cause a facultative myiasis. And many of the larvae of these flies do resemble New World screwworm larvae. And so that's why it's really important for any larva of any myiasis right now to be sent for morphologic identification so that we can tell the difference between New World screwworm larva and a larva from a facultative myiasis. Okay, so time for poll question number 4. Which adult fly is the New World screwworm fly? Okay, great job, everyone. Um, A was the New World screwworm fly. It's in the family Calliphoridae or the blowfly family. And as we mentioned before, it's blue or blue-green with 3 darker, nearly black patches that run down its back. Now, the trick and the challenge is that these other 2 flies do also look similar to New World screwworm flies, especially to those who aren't familiar with what the flies look like. And so we are already getting questions and inquiries from the general public and from others who mentioned that they might have seen a fly around and are asking if it's New World screwworm. So you may also start getting questions from your patients as well. So the number B, the option B, was the flesh fly from the Sarcophagiae family. It's gray or black with very stout bristles. And this one is very, very common and widespread. It's often associated with eating decaying flesh of dead animals, but it can be a known cause of facultative myiasis. And then number C was the green bottle fly. It's also in the Calliphoridae family, the blowfly family that New World screwworm is in, but it lacks the 3 stripes that New World screwworm has. It's very common and very widespread, and it's associated with rotting organic materials. So you might see it around feces or food trash or decaying wounds. But it's also a common cause of facultative myiasis in the US. Outside of the US, the flies that we need to have on our differential are flies that cause furuncular myiasis. And there's 3 different kinds of flies, the Dermatobia hominis or the human botfly. This one is present in Central and South America, and the Cortylobia anthropophagia or the Cortylobia rohania flies that are present in Africa. And the Cortylobia anthropophagia fly is the African tumba fly that you may have heard about. All 3 of these fly larvae penetrate intact skin, which is different from what we said about New World screwworm larvae that prefer to penetrate a wound and they lay eggs near a wound. The botflies lay eggs on blood-sucking arthropods like a mosquito or some other arthropod, and only a single larva is transferred when the vector takes the blood meal. The tumbo flies and the lens flies lay eggs on dry surfaces like human clothing. So if you're drying your clothes outside and they lay the eggs and then you put the clothes on, then they will penetrate the skin once you've put your clothes on. So typically there's only 1 or a few lesions that are usually on exposed skin, and the infestations in these cases remain subdermal. They don't burrow deep into the skin like the New World screwworm larvae do. But there's still itching and pain and potentially a sensation of movement. And so the patients will still come in with those similar complaints. And so again, morphologic examination is necessary to make sure that you have the correct identification of these larvae, both for patient care and for the public health. The picture on the right, you can see quite a difference in size between the Dermatobia hominis larger larva and the New World screwworm smaller larva. There is also an Old World screwworm, if you are not aware. The Old World screwworm is Chrysomomia bizania, and it has an almost identical life history to New World screwworm. The differences are that on average it lays about 175 eggs, which is fewer than the New World screwworm female flies. They still deposit them within minutes, so it's still a very rapid deposit of eggs. And the infestation can still cause extensive tissue destruction, debilitation, and risk of death. The larva, though, can be easily confused with New World screwworm larvae, but there are morphologic distinctions, which is another reason why any larva needs to be sent for identification by a specialist. The distribution of the Old World screwworm larva is confined to the eastern hemisphere, and you can see the picture on the map. The area shaded in pink is where the Old World screwworm flies are typically found. So now let's talk about the New World screwworm human cases that have been occurring in Central America and Mexico during this outbreak. The Guatemala Ministry of Health recently released a report on the demographics of patients infested with New World screwworm since the first human case occurred in May of this year. As of the end of August, there have been 80 human cases reported by Guatemala, with 70% of them occurring in males and 30% of them occurring in females. You can see in this graph the age distribution of the patients infested with New World screwworm. While all age ranges have been infested, adults 50 to 64 years old have experienced the most infestations, followed by adults over 80 years old. In Costa Rica, human cases have been occurring since last year in 2024. The graph that I'm showing you right now only represents data from calendar year 2025, from January to August of this year. There have been 72 cases during that time frame. Of those 72 cases this year in 2025, 68% of them were in men and 32% of them were in women. You can see that almost all age ranges were infested, from age 10 to greater than 75 years. But by far, the most number of cases were found in patients who were over the age of 75. We do know about 2 deaths that occurred last year in 2024 in Costa Rica. The larvae were detected in the oral cavities in both of these cases. There was a lesion somewhere in the oral cavity in the mouth, and the larvae were present there. One patient had a disability with an underlying chronic condition, and we don't have any additional details for the second case. In Honduras, what has been published in the news has been that since from February to August of 2025, there have been 150 cases. And of those 150 cases, 68% of them were in men and 32% of them were in women. They mentioned that the age group with the most infestations was the 50 to 59-year-olds, although they have noticed infestations in children younger than 9 and in older adults between 70 and 79 years old. In Honduras, at least, the most common sites for infestation were the left lower limb in 41% of the patients and the head. We are aware that Honduras has had 4 deaths associated with New World Screwworm. We only have some information on 2 of them. The first death was in a 40-year-old man who was otherwise healthy. He obtained a New World Screwworm infestation and subsequently developed sepsis from this infestation and died. The most recent death was in a 19-day-old baby who had New World Screwworm infestation of the umbilicus. Despite undergoing 3 surgeries to remove larvae from the umbilicus and antibiotics to treat secondary bacterial infections, he developed multiple comorbidities and other complications during his NICU stay and ultimately passed away. We don't have a lot of information from Nicaragua, but we know that between the time of January and July 7th of 2025, there have been 124 cases reported. And of those cases, they mentioned that some of them have been serious and that some of the patients have had larvae infesting the face, the genitals, and the bust. And because of the number of infestations and the ongoing outbreak, the U.S. Embassy in Nicaragua published a health alert on July 7th, 2025, that's linked here. We have the most information from Mexico because they publicly release their epi reports every week. And their first human case was identified in April of this year. From April until August of 2025, 48 cases of human New World Screwworm cases have been detected in Mexico. Of those 48 cases, 71% occurred in men and 29% occurred in women. You can see the age distribution breakdown in this pie chart. The most number of cases occurred between the 50 to 79-year-old age range, followed by 15% occurring in 40 to 49-year-olds, 15% in 70 to 79-year-olds, and 15% in 80 to 89-year-olds. There were cases in children between the ages of 10 to 19, and then there were cases in every other decade older than 10 to 19. Of the underlying conditions noted in these reports, 27% of patients did not have any underlying conditions despite having an infestation. 17% of patients had some sort of cancer underlying condition. 10% had diabetes mellitus. Alcoholism was noted to be a risk factor in 8% of these cases. And then the other 38% had an accumulation of other potential comorbidities or risk factors. Again, the left lower limb seemed to be the place where most of the infestations occurred, with 29%. The head and neck, or the head alone, was infested in 40% of the infestations. The nose and oral cavity of 8%, the right lower limb in 6%. And then of note, there were at least 2 patients, there were at least 2 patients where the uterus or genitals were infested, and one woman had a uterine prolapse that required a prolonged hospital stay due to infestation in the uterine prolapse. So now let's talk about some of the travel-associated New World screwworm cases. Travel-associated New World screwworm cases occur occasionally, but are important to detect because delays in diagnosis can lead to poorer outcomes for the traveler, and inappropriate handling of larvae could introduce the larvae into new environments that could support establishment of the fly. And because travelers don't pass through inspection points like animals do, they may transport the larvae outside of areas where USDA's interventions are currently ongoing. So we'll look at a few of the travel-associated cases in the US and Canada in the past. The first one we'll talk about is from 2007. There's a published case report that was published in the literature about a 12-year-old female who traveled to Colombia on a mission trip, and she returned to the US with New World screwworm in her scalp wound. She had an untreated scalp psoriasis with excoriations and noted intense pain in the parietal scalp 5 days after arriving in Colombia. She sought care at a local clinic, and they administered 1 dose of IV gentamicin and then prescribed her a course of oral cephalexin. She returned to the US for medical care due to this escalating pain. When she was examined in the US 4 days after symptom onset, her exam showed 10 different punched out ulcers that were 3 to 4 millimeters, with a larger 7 millimeter ulcer in the right parietal scalp. There were larvae in each of the ulcers and an oozing, foul smelling yellowish exudate that you can see here in the picture. In total, there were 142 larvae that were removed from the scalp, and they were identified as New World screwworm. In 2014, a case report was published of a 26-year-old traveler who went on vacation to the Dominican Republic and returned to Washington State with New World screwworm in her ear. The report indicates that she fell asleep on the beach and then later noticed otalgia and bloody otorrhea with a sensation of movement inside her ear a day or so later. On exam, she was found to have some soft tissue larval infiltration that extended all the way to the temporal bone with tympanic membrane perforation, but no middle ear involvement. She required a tympanoplasty with a skin graft, and the larvae were identified as New World screwworm. There was a recent case reported from 2014 where a 15-year-old female who went on a hiking trip to Peru for 3 weeks came back with New World screwworm. She had an underlying condition called Darier's disease that caused chronic scalp lesions. And during her trip, she noticed that she developed an intense focal headache. When she sought care, they noticed the scalp lesion and they applied bacitracin ointment. And then ultimately, larvae were emerging and they removed 45 larvae from her scalp wound. More recently, in 2024, there was a traveler who returned to the US after a vacation in the Dominican Republic with New World screwworm infestation inside of his nose. He had a history of malignant tumor that had been removed previously, and he was immunosuppressed. He sought care in a hospital in Florida and was later interviewed by the local news station. And again, you can click on the link and see the video of the larva being removed from his nose. But they removed 150 live larvae from inside his nose and his sinuses. This year in 2025, there was an 80-year-old man who traveled to Costa Rica and returned to Canada with a pocket-like wound on his leg after he sustained a minor injury in Costa Rica. He had over 30 larvae removed from the leg wound when he went for surgical evaluation, and CDC confirmed the diagnosis and the case report was published. As you may have heard, last month on August 4th, CDC confirmed a travel-associated case of New World screwworm in a traveler returning from El Salvador. The patient was treated and has recovered, and the larvae were accounted for. Press releases about the case were disseminated by Maryland, the USDA, and HHS. USDA initiated proactive surveillance to ensure no New World screwworm flies were detected in the area. And you can click on the link here to read more about that press release. So CDC has travel pages, and the CDC Central American and Mexico travel web pages now have an alert box stating that cases of New World screwworm have been reported in each of the Central American countries and Mexico. I took a screenshot of the page from Belize just to show you what it looks like when you click on the travel associated web page for Belize. you'll see that there's an alert box at the top that describes the cases of New World screwworm myiasis in those countries. For the countries in South America that are endemic, New World screwworm is mentioned in an area of the webpage a little bit farther down, where it talks about how to avoid bug bites, and New World screwworm information is linked there so that travelers who may be going to a country in South America where it's endemic can learn more about the flies. All right, time for poll question number 5. A 25-year-old patient presents to the urgent care after returning from vacation to Costa Rica. She has no past medical history. Her main complaint is a wound on her leg. Differential diagnosis includes which of the following: cutaneous leishmaniasis, New World screwworm, Dermatobia hominis botfly, cellulitis, or all of the above. All right, good job, everyone. The answer is all of the above. Any of these, several of which are parasites, could potentially be the cause of this patient's condition. And so again, it's important to keep New World screwworm on your differential when you're evaluating someone with a wound that's painful and has currently returned from Central America. Okay, so now we're going to talk about New World screwworm larva recovery and handling if you do have a patient with potential larva in their wound. As I've said before, removal of all larvae is key to treating the patient, and killing all larvae is key to preventing onward spread of the parasite. So the larva can be collected and placed in a leak-proof container with 70% ethanol, with a volume sufficient to fully submerge the larva. This will kill the larva and allow them to be preserved for confirmatory diagnostic examination. If you don't have 70% ethanol, then you can use 70% or greater isopropyl alcohol or 5 to 10% formalin. We request that you submit at least 10 larvae for clinical morphologic identification, and please do not discard any live larvae in the trash or throw them on the ground, as this could potentially allow propagation of the life cycle. If you have remaining larvae, because the patient has more than 10 that you've extracted from the wound, collect all of the larvae in a separate leak-proof container and fill the container with enough 70% ethanol or 70% or greater isopropyl alcohol to kill the larva. Place the container in a Ziploc plastic bag, seal it, and dispose of the sealed bag in the biohazard waste. I mentioned this earlier, but if you have a suspect New World screwworm patient, we are available for consultation, and we are available 24/7 because, as I said, it's considered a public health urgent event. And so you can call us during the daytime hours at 404-718-4745 or reach us through the parasites@cdc.gov email address. And outside of regular business hours, which includes weekends and holidays, if you are concerned that you have a patient who might have a New World screwworm infestation, please reach us at the Emergency Operations Center's number 770-488-7100. And as I mentioned, our diagnostic lab has a way to do assistance, both telediagnosis and formal diagnosis by submitting samples. And you can email them at dpdx@cdc.gov to request this diagnostic assistance for any larva that you may have in your patient. We request that you report suspect cases immediately to the State Health Department. So to provide a little bit of information about our CDC domestic response preparation and case reporting activities, CDC's role in the domestic response planning is to support USDA's preparedness and response efforts. They are the lead agency to address New World screwworm, but we're trying to ensure that human cases can be rapidly identified, rapidly diagnosed, and rapidly reported. And we want to ensure that USDA has the information they need to implement any control or surveillance measures for New World screwworm. We are collaborating with other federal partners as well, and we are supporting state, tribal, and local public health entities. We respond to any human cases of potential New World Screwworm in the US, and we're trying to raise awareness among healthcare providers, public health practitioners, and laboratory personnel. Just to give you an idea, we also respond to inquiries from the general public and from healthcare providers, veterinarians, and public health practitioners about any parasitic infection, but also about New World Screwworm. Last year in 2024, we received 12 inquiries about myiasis in general and 9 inquiries about New World Screwworm. You can see that in 2025, as of September 5th, there were 11 inquiries for myiasis in general and 70 inquiries for New World Screwworm, which includes inquiries from healthcare providers, public health departments, veterinarians, and general public. And of those 70, 47 were from the general public. So people are asking about it because it's been on the news. And so I'm anticipating that you may receive some inquiries from your clinic as well. Our DPDX lab, the diagnostic lab, had 7 submissions in 2024 for myiasis, and of those, 6 were confirmed myiasis and 0 were New World Screwworm. In 2025, as of September 5th, they had 12 total submissions, and these are only from the US, not external to the US, 8 of which were confirmed as myiasis, and 1 was confirmed as New World Screwworm, which was the travel-associated case that we mentioned earlier. If a case of New World Screwworm is confirmed, the state or local health department will undertake an investigation using the case report form and the investigation guide that we have developed and which are pictured here. All larvae will need to be accounted for, and pertinent information from the case report form and the investigation will be shared with USDA so they can implement any needed control or surveillance measures. Northward spread of the fly is being monitored by Mexico and the US. We are monitoring for both imported cases and local transmission. The definition of local transmission is cases that are occurring because the fly is present locally, versus an imported case obviously started somewhere else and was moved into the area, and there aren't presently flies in the area. Continued ongoing spread of the fly in the local area is what we're trying to avoid and trying to identify quickly so that USDA can address it. But CDC will release a HAN, a health advisory notice, when there is a locally acquired case of New World Screwworm identified in a northern state of Mexico that is bordering the US, or if the fly is detected by the USDA border surveillance that I mentioned earlier. All right, time for the final poll question. You evaluate a patient and are concerned about possible New World Screwworm infestation. After examining the patient, appropriately removing and disposing of the larva in 70% ethanol, the next steps are to which? Pick any and all that apply. The options are consult other physicians on social media, read about myiasis on the internet, consult the local infectious disease team, call the state public health epidemiologist, or consult CDC at parasites at cdc.gov for clinical inquiry and DPDX at cdc.gov for image diagnosis. Okay, perfect. So I anticipate that you will be consulting the local infectious disease team, and therefore it's important that all of the infectious disease physicians are aware of this in case they receive consults. But what we ultimately want you to do is to call your state public health epidemiologist and to consult us at the CDC at this email address or submit the sample to the lab. So where to find additional information? We have created some website materials for the general public. These are both in English and in Spanish and available online at our website through these links. And we have also developed some educational materials for healthcare providers and laboratorians, both in English and in Spanish, available on our website. Many other agencies are involved in this response, as I mentioned. And so if you're looking for information from USDA or from the Department of Interior or from the Food and Drug Administration, they are found at these websites. And this is a sad little picture just to remind you that animals, especially companion animals, are at risk for this infestation as well. So thank you very much. This is the end of my presentation. I'm putting our contacts up here one more time so that you have them. And this is a picture of all of the larvae that the USDA lab has collected over the years in their New World Screwworm diagnosis. Paula, I'll turn it over to you.
Great, thank you so much. This was a lot of information. We've gotten some good questions in the Q&A, and I just want to stop for a moment and thank you for sharing all of this information. Remind everyone that you can put your question in the chat. I do see a couple people have raised their hands. We'd prefer it to go in the chat for, I mean, not the chat, I'm sorry, in the Q&A. There's a button at the bottom. We have a chat and we have a Q&A. If you could put it in the Q&A. I think we also may have a few people that are on phone. I don't know exactly how we can get your questions just yet, but I'm going to go ahead and look over here at our Q&A. We had kind of a question that kept coming up quite a bit about if there's a reason why the left lower limb seemed to be a common site of infestation. We had quite a few people ask us about that same question.
I don't know the answer to that. When I was reviewing all of the information that we have access to for the Central America and Mexico cases, I was surprised as well to find out that that was the most common site. So I don't have a reason.
Okay. Sometimes we don't have all the answers. I know if you also look at the answered chat questions, you can see quite a few questions have been asked. And thanks to Dr. Montgomery and Dr. Fox for answering those. Any reason why you think men are more frequently affected?
Presumably, they might be the ones who are going out into the agricultural areas, working around livestock, going out to do some of the farm work. And the flies are infesting livestock and animals first, as we said, before humans are infested. And so presumably they have a higher risk factor just by their occupational exposure.
That makes sense. Thank you. Another question. What is the mechanism leading to the infection of the uterine prolapse or the uterus?
Again, the fly will infest any mucous membrane. And so I don't know this particular patient's story, but the fly had access to that area, and for whatever reason, that was where it decided to invest.
I think that was a tough question. Um, let's see. Do we know if I'm just looking here. If a patient is admitted or into inpatient and acute care settings, do we know how long is contact precaution maintained and indications for discontinuation of contact precaution?
So that's a good question and somewhat tricky because obviously if the infestation causes a bacterial infection or sepsis, it depends on which bacteria is involved. And so if you have a infection that requires contact because of the bacterial infection, then you would want to maintain that. There's no person-to-person transmission of this. The life cycle requires the fly to lay the eggs and then the eggs to develop into adult flies before the adult flies can then lay more eggs. So once the larvae are removed and extracted from the wound, there's no additional risk from a human to human transfer status.
Thanks. We had another question about pets crossing the border with their owners. I know we have a lot of that here in San Diego, especially. Is there any push to require, and I'm going to get this wrong, but isoxaxolines, class drugs? Maybe you can see that in the Q&A and tell me what that means, but they appear to be very effective against larvae, according to the person asking the question.
Yeah, that's a good question. And we've faced a fair number of questions about dog importation. It USDA actually has the regulatory authority over a dog importation for New World screwworm specifically. So I would refer this person to the USDA website so that they can find that information hopefully there.
Okay, great. Thank you. Let me see. Think there's still some questions coming in, and while you all are thinking of your questions, which thank you, these are great questions. Um, I think as a teacher, instructor, faculty, we always say there's no dumb questions, so we always appreciate them. This was a pretty heavy topic. Um, while you all are doing that, just really quickly, if you want to check the chat, we had, because of the changes in our login and registration, thank you all for your patience with us as we had to switch to a new link that had more capacity. Several of you may have shared your link with someone else, and so we have duplicate names. We would love to know who you are, just so that we can correspond with you about whenever we post the session online, the recording, and also the PDF of the presentation. So if you put that in the chat, not the Q&A, but the chat, we can see and record that and make sure we have everybody that attended recorded, especially if your name popped up as somebody else's name. That's really helpful. And also as a reminder, I believe my colleague put the if we'll put the evaluation link in the chat. We need to make sure everybody is able to fill that out. Okay. We have a comment. We have a comment from Shannon McBride, who I know is a doctoral student and practicing veterinarian here at my institution. She has a link here about the FDA having a list for veterinarians of medications that can be used, if you all can see that.
Yes,
And
and two of the links that I put at the very end from FDA also include information for veterinary treatments.
awesome. I think also too, just also some of the obviously people can't click on the links right now because they're not a live PDF, but we will post again this recording within a week on our website. I think somebody has already put in the chat a few times the link to that. And then we'll also send out an email. If you've registered and we have your email on file, we will send you an email with a link showing that we've got the PDF posted and also the recording. I'm thinking in the PDF we can make them clickable links. That's my hope, so that you should be able to click on those links. Let's see. How long minimum time the fly has to be on a wound to lay eggs? I think Mark is answering that question, but I don't know if you want to take it.
Yeah, that's a good question. It's pretty short. They can be on the around the wound on the wound for a matter of seconds to minutes and deposit quite a number of eggs. So it doesn't take very long.
This is Mark. Just a little more detail on that. Where there's a lot of old case reports from back when this was endemic in the U.S., where the patients attested that the fly only sort of briefly landed on them and they brushed it away. And so only a few eggs were laid, and there were only a few larvae in the infestation. But the infestation can still be quite severe depending on the tissue that's impacted. For instance, if it's the sinus or the ear, doesn't take much. That was my only addition. Thanks.
Thanks, Mark. Any other questions coming up? I've got somebody asking for the QR code. We're going to switch the slide here in just a moment to show the QR code for the evaluation. I think, Cato, you're going to do that. I also see, Leona, you have a hand raised, but I'm wondering if you can put your question in the Q&A, if that's possible. Okay, gotcha. Thank you. If anybody else also has their hand raised, please feel free to put their question in the Q&A. Also, a couple of questions coming up. We have two more sessions that we're going to be doing at the same time next Monday and the Monday after that. Those is a two-part series designed for community health workers. All are welcome to attend. However, just as a note that we've divided this same content out, but into two separate sessions as it's geared more towards community health workers. However, we will not turn anyone away from attending. So if you do have community health worker network you'd like to tell about these sessions, we'd love to have everyone. And those will be for CEUs. I'm checking to see if we can do CMEs also for anyone who does attend. But again, this will be same material, just divided up into a little bit of a slower didactic. So we'll go over it in 2 different sessions. We have a question coming in. What are your preventative recommendations? That's a great question.
So I mentioned that in one of the slides, ideally avoiding exposure to the fly, which obviously is hard to do if you're outside and working around livestock where there might be flies. This is in, areas where the flies are currently present. The flies are not currently present in the US. But in areas where the flies are present, keeping your skin covered, so the long sleeves, long pants, a hat to cover your scalp, not being outdoors during the daytime when the fly is active, preventing bug bites and other wounds, making sure that you cover wounds and clean the wounds immediately and quickly. That's the best way to prevent exposure to the fly.
Great, thank you. Also, just in the chat, a couple people have asked if the QR code is the same as the survey link shared on here. It should be. If anybody sees that it is not, please let us know. Great. Yes, it should be the same link. Let me just double check that that's working. I'm going to click on it myself and make sure it's working. Yes. So it's a short evaluation, a couple of questions that you asked also at the registration. Thank you all for doing that. Also, question, is there a link for the community health worker sessions? Community health worker session link. Can we put that in the chat as well? For now, it's going to be the same link that's been on the flyers. Maybe we can also put a copy of the flyer. And again, because of the registration, we're probably going to have to switch over to the same webinar link. All right, so just go ahead and register for it underneath the registration that we have, and the same thing will happen when we'll send out a new link if we surpass the 300 mark. Another quick question, when do we receive our certificate CEUs? We ask that you give us about 3 weeks, especially since we have so many people, but we will send them by email. Please make sure that you have put your email address and your name in the chat just to double check that we have it in multiple places. We know you were in attendance and that we can send that to you. Okay. I think Mark is also answering a question. Oh, I think he just answered it. Never mind. You all can see that in the chat. CEU credits for public health nurses. I believe that right now we just have CMEs for continuing medical education and then the CEUs for the community health workers. I apologize for that. Getting nurse CEU credits is way more difficult for some reason. We have discussed this maybe in the future, but we do appreciate you being here. So thank you. Hope that was a good answer for that. Any other questions about the topic as you're thinking? Mark or Sue, do you have anything else you'd like to add? Or Rebecca, anything you can think of that might be?
I would just like to reiterate the technical lab hotline email is dpdx@cdc.gov, and I'm one of the handful of people that attends to that. And if you think of technical questions or things you're curious about later, please don't be shy about writing to ask, and we'll be happy to give you the best answer we can. Thank you,
Thanks, Mark.
everyone.
Mark, can you put that in the chat, the email address? Pretty please. And Sue?
I have nothing to add except you can always contact CDC if you have questions about this. And for clinical consults, our email address is parasites@cdc.gov.
Thank you. Roxana asked the question, what would be a realistic situation of someone being exposed to this? I know you presented a couple of case studies here. I don't know if you want to elaborate on anything else.
I mean, I think what I'd like to emphasize is that any person can be exposed and be infested. And so you can see, based on the case data from Central America and Mexico, all age ranges are infested, both sexes are infested. There are some potential underlying conditions that increase the risk, but primarily just having a wound increases the risk. And that can be from falling or from a mosquito bite or a tick bite. And so I think for your patients, it's important to consider this for anyone. Obviously, the people at higher risk, as I mentioned, are potentially the people working around livestock who are outdoors a lot, who, might be around cattle or farm animals. But we know from data in Central America and Mexico that there are a lot of dogs infested, there are a lot of wild animals infested, there are a lot of other, cats, other animals. And so because the fly doesn't really have a preference, it's not one of those that only prefers to infest sheep or only prefers to infest horses. Any warm-blooded animal is at risk. So, as we said, cover your wounds, make sure to heal your wounds, cover your skin to avoid the fly having access to that. But in your differential diagnosis, as you're considering what may be causing problems in your patients, keep this in the back of your mind. If the patient has traveled from an area that is endemic or currently experiencing the outbreak, right now there is no New World Screwworm in the US, and so we don't expect anyone in the US to have it if they haven't traveled. But as I said, there's been several cases of travel-associated New World Screwworm infestation. And so if a patient is presenting with myiasis, we have to consider New World Screwworm if they're coming from those endemic or outbreak-associated countries.
Great, thank you. Also, another question, I don't know if you know the answer or not, but which topical larvicides have been shown to be effective?
Again, the FDA and USDA would be the best answer for that for animal cases. And in humans, obviously, we would not recommend any of that.
Thank you. Just that's a good point to be clear about. There was a question from Maria about, I always get this name wrong, if we could expect eosinophilia, I always get that wrong, I apologize, on labs or other important lab abnormalities to be aware of.
Eosinophilia. That's a good question. So I think it depends on how destructive the larva is and where the larva would be present. It's not like some of the other parasites that are internal and in some of the tissues that would prompt an eosinophilia reaction. Personally, I haven't seen the laboratory results on the patients who've been infested in Central America or Mexico, so I don't know. I don't even know if they've had labs. So I don't have enough data to answer that question. But the presentation of each of these patients will vary based on where the larvae are infesting. So if larvae are infesting the head and neck region, that's a very different presentation than if larvae are infesting the leg or, the umbilicus in that baby. So the answer is I don't have enough data to answer that, but the presentation is variable based on the location of the infestation.
Thanks. Hey, I'm just looking, there's another question. What is the regulation regarding sharing limited details about travel-related cases in the US? Is this normally permitted or only because it's an emergent issue?
So all of these cases that I presented today have been published in the literature. And so once it's published in the literature, it's available for anyone to download those case reports and read them. And the links are present in the slides for you to find as well and read if you want. The one patient whose case was not published in the literature, he did a media interview. And as I said, you can click on the link and watch the video. It's quite a disturbing video, but I think it will give you a good idea of what a patient experiences when the larvae have to be extracted from their nose. But because of HIPAA requirements and because of patient privacy information, we would not share information unless it's publicly available through a case report study.
Great, thank you. Right, I don't see any more questions right now coming in. I think we've also, I want to say thank you to Dr. Montgomery and Dr. Fox for answering a lot of the questions in the Q&A. Also to Dr. Chansey for your presentation and sharing your expertise. I know we're about 10 minutes early doesn't mean we can't, I mean, we can still stick around. But I also wanted to at least remind everybody that this session is recorded. We will make it available online at our Echo website, which we've put in the chat. We'll also send an email out with a link to the evaluations if you happen to miss it. Again, if you are signed in as somebody else, it's really important that you put your correct contact information in the chat. We're recording that as well. CME certificates will be issued in about 3 weeks following the session. You'll get them by email. You can also reach out if you have questions. This is our Shaga's email address, shagasus@gmail.com. That's a good way to get a hold of us, or mostly me. I'm the one checking those emails. And then as a reminder, we're going to do 2 more sessions for community health workers, but others are invited, including public health professionals, on September 22nd and 29th, both for an hour and a half long at the same time. If you did not receive a flyer to that, when you registered for all 3 sessions. So for those of you who don't plan on attending this 22nd and 29th sessions, please disregard the future communication about that. But if you would like to attend those others, you've already registered. And so you'll be getting the link emailed out to you in your email because you've registered. And again, please disregard that if you've already attended this session and don't plan on the next 2 sessions. But if you want a refresher, you can also come to those sessions as well. All right. Any other questions? Let me just check. So far, I don't see any more questions. So, I mean, with that, we can all maybe recuperate another extra 8 minutes of our lives right now. And I want to say thank you so very much to our presenter. This was really good information. If you do have any questions, I believe we've put in the chat who you can contact. And again, we will make this recording available. And I think with that, we can go ahead and close out the session. So thanks to everyone. We had quite a bit of attendance. So hopefully you got a lot of your questions answered. And again, next 2 Mondays, we'll have the community health worker sessions. Please share that with your networks. And I think that's everything. We're going to stay on for a few more minutes, just so people can put their info in the chat if you've missed it and you have another couple of minutes. But for the most part, if you don't have any questions, please feel free to log off. And thank you again for joining us today.